The Shift is brought to you by SE Healthcare. Welcome to The Shift. I'm Dr. Andrea Coyle. Shifties, welcome back to the next episode of the Shift podcast. With me today is Anne Dabrow Woods. Did I say it right?
Yep, you said it right.
And Shifties, for y'all listening, this conversation is going to be really organic. It's going to be genuine. It's going to be exciting. And take it from here. Tell the Shifties a little bit about your career, some of the highlights, and then I'm going to jump into some questions that I think the Shifties are going to be really interested in hearing from you.
So thanks so much for having me today. So I'm Anne Dabrow Woods. I've been a nurse for over 41 years, which is hard to believe. I've been a nurse practitioner since 1998. I have spent a lot of my time working in critical care, and I decided to go back to school and to become a nurse practitioner, which I did. And then when I was graduating with my nurse practitioner, um, one of my friends who worked for a publishing organization says, "Why don't you come and be an editor?" And so I, went ahead and I did that. And I worked my way up into that organization and actually became the chief nurse of Wolters Kluwer Health, Learning, Research, and Practice. And I did that, Andrea, because, they're a pretty big player in the nursing space, but they didn't have a chief nurse. And I thought, well, we need somebody who can really understand what's going on in practice and nursing education today, who can lead the strategy. So, as nurses do, I developed that job description, that project plan, presented it, and the next thing I knew, they said, "We would love you to be the chief nurse." So I did that for about 15 years. And about a year and a half ago, I decided to kind of take a step back and do what I absolutely love. So throughout my whole experience, I've continued to practice as a nurse practitioner. I'm dual certified in acute care, critical care, as well as primary care. So I've continued to practice, but I also have taught. I taught undergrad at the master's level and then at the doctoral level as adjunct faculty. So about a year and a half ago, I decided, you know what, I want to do what I absolutely love, and that's to teach. So I took a full-time position at Neumann University. I run their DNP program as the coordinator. I teach in their master's program. We have several NP programs. And then believe it or not, they have me teaching undergrad as well, which I absolutely love, cultivating these new minds that are coming up and are going to be eventual leaders in our profession. So yeah, that's kind of who I am. Love practicing, love teaching, just feel like I need to give back to the profession that's been so good to me.
Wow. Oh my gosh. So let me tell you something that's really interesting, Anne. Yesterday, I met with Kirsten Labar. She is the Associate Chief Nursing Officer at the Medical University of South Carolina. And I'm asking her, I want her to come on to the shift and be a shifty as well. And she is a pediatric nurse practitioner. She is an ACNO, and she still also does 2 shifts per month using her nurse practitioner license, which I think is amazing.
Well, that's great. And that's actually what I do. I work for Penn Medicine, Chester County as a critical care nurse practitioner. And I have to say, I love it. And it keeps me grounded and it keeps me aware of really what's going on in practice today.
I think it's critically important. I do have a couple of questions, and you and I had a couple of really great conversations offline, but can you just tell us why it is so important for nurse faculty to maintain a presence in clinical practice?
Well, I think we have to really think about why we're there to teach. We're there to teach because we want to prepare this next generation of nurses that are coming up so they really can be okay and be successful in the practice environment. And in order to do that, we really have to understand what's going on in healthcare practice today as nurses. And the truth is, Andrea, the practice setting is different than what it was, say, 10 years ago before COVID. Throughout COVID and post-COVID, we saw a lot of mergers, acquisitions, consolidations, and closures happening where, we are faced with today a situation that there's actually, no downtime in nursing anymore, right? Because We don't have enough beds. We know that there's a shortage of nurses at the bedside. And the patients we have because of COVID are so much sicker than they were ever before. So the work of nursing has really evolved. And in order to teach our nursing students that are coming up, we have to understand that. And we have to make sure that they are able to function successfully in a situation that's really different. And you can't teach that if you don't know what's going on. Now, I just want to say, I'm not saying that every faculty person needs to go back and be at the bedside, 1 week in a month, like I'm doing or whatever. I'm not saying that. What I'm saying is you need to go in, you need to look to see what's going on in actual practice today. You need to talk to people who are in practice, talk to the leaders in practice settings to find out what they really need of these new nurses that are graduating and then becoming the workforce. Now, I'm a big proponent of clinical practice for faculty. I teach NP students, I have to be in active practice, but I will say being in active practice has really helped me do a better job teaching my undergrad students because I can give them real life examples and stories and different cases, and we can work on them together, especially like in our sim lab. And if I wasn't in active practice today, I wouldn't know what those stories, what those real life events are really all about.
And talk to talk to me a little bit more about the real life stories and the power of storytelling.
Well, we talk about healthcare. We talk about, that we work in what's called the service industry. We're really not a service industry. We're an experience industry. And we need to understand that these people are coming in sometimes at the best times in their lives, but most of the time at the worst time of their life. And we need to be able to communicate those stories that this is a person who happens to have a disease or condition. We need to be able to communicate that to our students and help them walk through that experience and learn from it. So, so often, and I'm sure when you and I went to school, we sat in big classrooms and somebody was up there lecturing, doing the whole didactic thing. And honestly, what did you really get from that? Well, you really didn't get anything from that unless you were able to apply what you just learned in a clinical situation, right? So being able to take these patient stories and situations and bringing them to life for our students is so very, very important. A good friend of mine once said that for every hour of didactic, we need to have an hour of actual clinical practice or simulation where we actually immerse students into that application of learning. And I absolutely agree with them because that's how students really learn, if they can be in it and experience it for themselves.
I like that. And I think this is a great segue into my next question. How must we rethink the way we train new nurses so they are clinically competent, but they're also adaptable and prepared to lead in today's healthcare environment, which, as you mentioned, Anne, looks way different today than 31 years ago, 41 years ago for you. And so that's one question, Anne. And the other question is, in your experience, your current experience, do you believe that student nurses are starting to feel burnout before they even transition over to the practice environment? Those are a lot of big questions. So
A lot of big questions. So let's hit the first one. So
yep.
you said a very loaded word, competent,
Yeah.
right? And I think that, our whole idea of competency. Now, I don't know about you, but for years, when I was being assessed for my competency, it was a checklist. You had to go
Right.
do the task and it was a checklist. Well, obviously our profession has wised up and realized that does not mean you're competent. And that really the whole definition of competency is being able to be immersed in a situation, recognize there's something going on, knowing how to react, knowing how to apply that knowledge, how to actually do the skills, and then educate the patient and then take it to the next step, right? So I think the American Nurses Association has actually done a really good job defining competency, and we're really starting to integrate that into our educational process for nurses. And I do really believe in that. New nurses, graduate nurses, and nursing students, we need to talk in classrooms about, okay, what do you do if you have a patient with chest pain? What could that be, right? Talking about the etiology, how they're going to present, and then what you should do for that patient. And then immediately we need to put them into a situation, whether it be in a sim lab or a clinical experience, where they actually have to live that experience and apply what they've learned. So I think that's been a real shift for nursing. We need to be able to teach based on making sure our new clinicians are competent and that they actually get to apply their knowledge and be able to put it into their practice. So I think that's going to be a big shift. I think also we need to make sure we're teaching them the right skills. The bottom line is, Andrea, when a new nurse graduates, they pass their boards, they start working, the practice setting expects them to be experts. They're not. And this whole idea of being practice ready, we need to forget the fact, or we need to not forget the fact that these are still new clinicians, right? They may be competent at a beginner, but they're not experts, right? So we need to make sure that we understand that in the practice world. And we need to continually teach these nurses using different scenarios, simulation, real world clinical experiences, how to apply the knowledge that they've learned and then actually do the skills of nursing in their clinical practice. I do think we need to do more with new nurses around some of the skills. For instance, like making sure they know how to do a 12-lead EKG. They do know how to put in IV lines and nasogastric tubes and OG tubes and urinary catheters. Because I hate to say it, but nursing students get so nervous when they have to do those procedures. So let's do them a favor. Let's teach them how to do some of those skills before they get into actually real clinical practice when they graduate, right? We can do that in our sim labs because it's a safe environment for them. But we can't just teach skills without teaching them to really being able to be assessing the situation, using their critical thinking and their clinical judgment about the situation. And I think that's probably the biggest shift for us as educators. We got to get out of the big classrooms and stop, just focusing on the didactic and get more into the doing of nursing.
I like that. No, here's something that I thought about because I remember my first couple weeks in orientation as a new nurse and 12-lead EKG. Like I was a mess. I was shaking on a real patient. And I just remember, I think those are the moments that it's so stressful and you feel like you have to do everything right. And you feel like, you said this, I was new. But I felt like I was being judged. And I think that started to contribute to early burnout in my career is because I worked adult med surg and you never knew what was going to happen next. And you were never going to know that your 8 weeks of orientation. But let's step back into the student environment. Do you think that there is burnout starting before they even transition over to actual practice?
Absolutely, I do. And I think that we need to do something as a profession to help address that. And one of the best things we can do is to teach them self-care, right? How to recognize those signs and symptoms that they're getting burnout, they're having moral distress, whatever they're feeling. Acknowledge that those are really real feelings and teach them how to deal with that. The bottom line is nursing school next to engineering, we're probably the two hardest professions, right? Nursing and engineering. That's not going to change, but we need to be a little bit more forgiving and stop being so judgmental. Our students are learning. And we need to make sure that they understand that it's okay not to be perfect. And we don't expect them to be perfect in the learning environment. And even when they go out there and start practicing, we can't expect them to be perfect because they're not going to be. But we have to teach them about self-help and how to really make sure that they can be resilient when they get into stressful situations. And also have a voice when they're not doing okay. So often we ask each other, are you okay? And we expect the pat answer of, yep, I'm okay, just need a minute. The truth is, we're not all okay, and that's okay. And we need to embrace that and say, all right, you're not okay. What can I do to help support you? What can I do for you now? Um, and I think that we need to start teaching that and believing in that and practicing that whole idea around self-care in the beginning. Because, Andrea, if we don't, when these new nurses get into an actual practice setting, they're going to be gone within the first year or 2 years. I mean, the research in this is really clear. If you look at new nurse grads, 24% leave our profession within the first year. And by the second year, up to 19% more leave. That's a failure on our part. It's a failure in nursing education. It's a failure in nursing practice. We need to work to change, you know, to help them learn how to deal with that situation and also really look at changing what's going on at the bedside.
And I think some of it is feeling empowered to speak up in a way that's helpful. But the preceptor on the other side, there also needs to be education for the preceptor on how do I meet this new nurse where they are? How do I
Right.
meet them where they are? And how do I speak to them in a way that's helpful, not hurtful? Like, I'll give an example. One time years ago in a med surg unit, we had a new nurse out of orientation, and it was something to do with a low H&H, and she didn't really understand why she was calling the physician. And instead of being helpful going through the list, I recall, I was a charge nurse, I recall the preceptor saying, oh my God, Carrie, I'm just making up her name. Carrie doesn't know what she's doing. She's calling the physician because the H&H was 7 and now it's 9. I don't know. I'm making all this up, but you know what I'm saying? And that was not helpful for Carrie, the new nurse, out of orientation, but still like fresh out of orientation, instead of being really helpful and meeting her where she is and say, guess what? You don't have to call the physician if the H&H has improved.
Right.
You don't have, but if it didn't improve, then you call the physician.
Right.
Those simple little things that really are powerful.
Well, I think if you look at the fact of how people become preceptors today and who our preceptors are, I mean, Andrea, back in the day, I'm sure you remember this. If they wanted somebody to be a nurse manager, they looked at who was the best clinician and said, oh, they're expert. Let's make him a nurse manager. Poof, you're a nurse manager without any training, right? So we all know that a lot of nurse managers leave because they get thrown into the frying pan and they don't know how to, work in that environment because nobody taught them. And the same thing's happening with preceptors. Gone are the days of a preceptor having 10, 15, 20 years of experience. Our preceptors today are nurses who've been out there, usually for just a few years, 2, 3 years. They're the ones that are teaching the new nurses, even though they're really newer nurses themselves. But we didn't take the time to educate them on how to be a preceptor. And that's one of the biggest faults of our transition to practice system. We need to make sure that we are training and educating our nurses on how to be effective preceptors. Because if we don't, they're going to burn out and they're not going to want to work with anybody who's new, right? The other thing is we need to get our new nurses out of these 6-week orientation programs, which are total waste because those nurses are going to leave the profession, they need to be in nurse residency programs, right? Where we can really nurture them and teach them and help them to be competent as new nurses, right? And those nurse residency programs have to last at least 6 months to a year. And then we can't be done. Now, a lot of hospitals, what they're starting to do is putting in this safety net idea where they have resource nurses, and a lot of them are nurses who have retired and want to come on back to give back to the system. But the resource nurses who are really experienced, who can be available to help our newer nurses at any time. And they might be there on the units, but a lot of times they're virtual. And we do know from the research that that could be really helpful because our newer nurses are feeling like they got a lifeline out there, right? Our preceptors feel like they have a lifeline. If they get into a situation with a preceptee that they don't know how to handle, they can reach out to this resource nurse to say, what should I do differently here to make this a meaningful interaction and a meaningful learning experience for this new nurse, right?
And I think you nailed it, Anne, when you said earlier in our discussion about we're not a service industry, we're experience industry. And how do we create this helpful experience for our new grads? And it's not just hanging up the right IV fluid or inserting the Foley catheter the appropriate way. It's how do we talk with patients that might need a social work consult, but as a new grad, we haven't picked up on it because we don't have the experience. And
Right.
there's those pieces as well. This is a really great conversation. I have another question for you.
Okay.
In your experience, what are we getting right in academic preparation, and where are we unintentionally falling short and preparing nurses for the realities of workload technology, team dynamics, and some of the decision making?
So I think some of the things that we're getting right today is that we're realizing that, hiring faculty who are still staying in practice and have a leg in practice is really, really important. And a lot of academic centers are allowing for a day of practice each week. And I think that's really, really important that the academic institution is supporting that. I do think that, our payment structure in academia is a problem. Our faculty, they need to be paid more. But we also need to understand that a lot of our faculty today, we need to take the time to teach them how to teach. Or I don't like the word teach. I like to say facilitate learning. What our students expect today is different than it was 10, 15 years ago. So as faculty, we need to continually learn how to best facilitate learning in our students, right? How to do that knowledge transfer. And I think that one of the things I'm seeing in a lot of academic centers is that they're working on that and they recognize that, which is really a great thing to see. I also see that more and more academic centers are recognizing that nurses don't have enough time in a clinical setting simply because we can't get the time. So we're going to have to do more with simulation, right? And I talked a lot about that earlier about why that's so important. And, besides it giving them a safe space, it really can help us teach them how to use their clinical judgment. But the other thing I'm seeing a lot in academic settings is that there's a lot of partnering with other healthcare disciplines. So I will tell you, one of the things that we do for our undergrad students is that we do a whole chapter on immobility and movement of patients. And we actually do a workshop with our physical therapy students where we actually go in with the physical therapy students, and the physical therapy students teach our nurses about transfer and walking with crutches and walkers and canes and all of that. And then we actually role play and do it together. And it's such a great learning experience. But the other thing that's really important, Andrea, is it shows that healthcare is a collaborative practice, right? We work in healthcare as a team. And it clearly shows these new nurses that the physical therapist is absolutely just as important as they are as the nurse. The other thing we do, and I've seen schools doing this, is they partner their MP students with new nurses and have them run different simulations like rapid responses or code blues so that the newer nurses can actually see, hey, we work together as a team. We're all equally respected for the talent and the knowledge we bring to the table, but working together really can help to improve our patient outcomes. So I think that those are things that, I see in education, we're doing better today than we've ever done before.
And I like that you said that. I was just, this whole conversation, I'm reflecting on when I was in orientation, and you nailed it. And I don't know if everyone's doing this, but again, we go back to that word experience and interprofessionalism. And back in the day, it felt like here was nursing. There's one silo of nursing. There's a silo of PT, OT, speech, dietary, physicians. And now what you described is the experience. We're going back to the word experience is so interprofessional. And what a great way to help our new to nursing practice nurses really get a holistic approach of what the patient needs to be successful on their healthcare journey. It's brilliant.
Yes,
And that was a big disconnect probably like 10 years ago, up to
right.
10 years ago. And there still may be that disconnect in some of our practice environments. I'm sure there is.
And the other great thing that I'm seeing is that a lot of nursing schools are working with their social work
Mm,
students because when you're talking about the social determinants of health, both groups, we got to assess that, right? But who better to learn that from than social work, right? How to ask those difficult questions, right? And have them help facilitate the learning of our nursing students and vice versa, right? So it's really showing that we have to have this collaborative approach in healthcare or our patients aren't going to benefit from it. And I think it also clearly shows the patient's got to be the center of everything we do, right? And we're just privileged to walk alongside them and help them make informed decisions. That's our job as healthcare professionals. And the information we provide to our patients has got to be not just nursing, it's got to be medicine, it's got to be social work information, it's got to be physical therapy, mental health support. We have to work as a team. And I think that's a great opportunity in nursing education to show them firsthand how that can be done.
I feel like we're dropping the mic today, Anne. So I always end the podcast. If you could give one tip to all the listeners today, what would it be as it relates to academia and then transition into the practice environment? And I know there's more than one tip, but if you could give one tip, what would it be to help continue to cultivate this great profession of nursing?
So I think that the tip I would say is we need to really understand that a new graduate nurse is not going to be perfect. They're still learning. And it's our professional obligation to help grow this next generation of nurses who are going to be the caregivers, who are going to be the leaders in this wonderful profession. And I think we need to stop, leave the judgment and our egos at home, and just realize we need to be there to support them. Not only is it our obligation, for our profession, but really it's what we should be doing anyway, right? As a profession and giving back to our profession. So leave the judgment at home and work to, help our next generation of nurses.
Anne, thank you so much for joining me today. Thank you for providing such insightful knowledge. And I'd love for you to come back on the shift in the future and we can figure out other things to discuss that are really important to us. And for everyone listening, Anne and I were talking, we've been having conversations before the podcast, and we both agreed that neither one of us have any interest in retiring because we are so passionate about this great profession. So shifties, remember, your shift makes the difference. Keep shifting. Enjoying the shift? Help us reach more nurse leaders by rating and reviewing us on your podcast app. It takes just a minute, but makes a big impact. Search for The Shift, tap those stars, and share what you love. Your feedback shapes our future episodes and helps others discover us. Remember, rate, review, and amplify The Shift today.